Good morning, everybody. We are in Madrid for the annual EAU Congress. I'm with Manuela Tutolo from Milan and Manuel Ritter from Bonn, Germany, two key opinion leaders in BPO and OAB management. This morning we have an interesting section how to manage BPO and OAB patients and a game changer section with some very important studies. So first question for you, Manuel, regarding your study, the water trial. So can you just introduce yourself and summarize the main results of the water trial?
Yeah, thank you for having me here. So we induced the Water 3 trial as a logical consequence of the Water trial and the Water 2 trial, showing superiority in safety for aquablation in larger prostates and the same efficacy, and especially in the Water trial in comparison to TRP in a randomized manner. So for us, the consequence was to apply this technique to the other gold standard in our center, which was laser enucleation of the prostate, which is performed only by some surgeons because it's rather complicated. And so we got this started.
And the main results of the trial?
Main result would be, this is early results after 3 months because we reached this endpoint in January this year. But we reached the same IPSS decrease with aquablation as with laser enucleation in prostates between 80 and 180 milliliters. And we had similar safety outcomes for both treatment groups. So the same bleeding rates without any significant difference, for example, but higher ejaculatory function after aquablation compared to laser enucleation.
And particularly on incontinence, that is one of the major problem after enucleation.
Yeah,
so
definitely.
What are your results in the Water 3?
The differences until 3 months was not significant, but we had 9% in after aquablation and about 20% in laser enucleation. And the difference was that 0% suffered from stress incontinence after aquablation, but 9% of laser enucleation patients did. Aquablation patients suffered more from urgency. One had mixed incontinence, but most of the patients had urgency, and but no single stress incontinence. And that's a difference, and we are very excited how that will be developed because we know that from laser enucleation. We performed it very often, and in most of the cases it decreases further, and we will see that hopefully after 6 months, but we will have to wait for that.
And how do you explain a less reduction in prostate volume after aquablation when compared to HoLEP?
Yeah, because we leave tissue on purpose, especially at the apex, and we cut less tissue. So we see a de-obstruction, but we still keep the ejaculatory function. And that seems to be the trade-off and is often discussed, obviously, but we did not find any real difference that matters for the patient.
And what are the main implications for clinical practice for our patients regarding the Water 3? Another option?
To my opinion, it's definitely another option due to 2 reasons. First of all, it's much easier to learn. So the cutoff to be part of the study was for the center to have performed 30 cases. And all published laser enucleation studies publish learning curves of at least 50 cases, and I'm pretty sure most of the learning curves are even longer. So learning curve is one issue. If you start doing that, you will be able to gain good results, because in our group, the experience in aquablation was rather low. So we had between 30 and 160, the surgeon who had the most experience. So even for us, it was possible to gain these results. And the second is definitely the ejaculatory function, which was, to my opinion, a lot out of the focus, especially of the surgeons. We focused very much on de-obstruction, but it is in the focus of the patients, definitely.
Thank you, Manuel. Manuela, we know that patients with BPO up to 60%, they have OAB, but OAB is not a specific male problem, male disorder. So what are the possible gender differences in OAB management and diagnosis?
Thank you, Cosimo, for this question, which is really interesting and also really debated in our everyday clinical life. Because actually, we normally deal with male patients, but also with female patients with urological problems. This means that we can have the same symptoms, OAB symptoms, but in two different genders with possible one factor in between that should be assessed, the prostate function. So what is the prostate role in these symptoms compared to women which don't have prostate but basically have the same storage symptoms as men? So what we should do is focus on the characteristics of patients in general, on the characteristics of symptoms, on what is much more disturbant for patients, and try to assess what is the cause of these symptoms, and then spend time in addressing the perfect mechanism and the perfect treatment for that specific patient. So gender different exists, of course, because when we assess prostates and patients with prostates, we need to know that there is prostate and something correlated, some symptom correlated with the presence of prostates, but we should not forget the presence of the detrusor, which is basically the same in men and women. And if we look at the prevalence of OAB in men and women, is more or less the same. So we shouldn't forget this, and we should treat OAB as OAB.
And particularly, how do you evaluate OAB female patients? What is your strategy?
Yes, actually, if we follow the guidelines at the moment, we have some strong indication in performing good evaluation of the patients, bladder diary, behavioral habits, and eventually modifications, but not perform in every patient's urodynamic tests, which is a key point, because we have always discussion on this point, because of course urodynamic in some patients can help in the management and in the assessment first and then in the management, but it's not for every patient. So we are looking for the results of the future study and other studies assessing the importance in specific group of patients with specific symptoms, specific characteristics, who can benefit of urodynamic in the first assessment in order to better understand the symptoms and better treat that patients.
And in female patients on menopause, do you believe that local estrogen, they have a role, maybe an option?
Actually, it's an option, in my opinion, completely, because we don't have strong literature on it, but we know from case report and all the literature that local estrogens can improve symptoms in women. So personally, I use in postmenopausal women to improve symptoms, also estrogen therapy, in order to have more than one option to improve their
You say
symptoms.
that we have to evaluate, better evaluate our patients, then we have conservative management, medical treatment, but when conservative or medical treatment and management, what is your strategy in female patients?
Actually, I really take a very, and it's very important to take a history of the patient and a good anamnesis of the patient, because we need to know what are the habits, what are the fluid intake, what are the characteristics of the patient. So if I understand that if I have in front of me a person, a woman who is postmenopausal, is drinking 10 coffees a day, she drinks a lot of cola, I would start to improve her behavioral habits, and then if I don't have any results, I will go for medical treatment.
Thank you, Manuela. Now, Manuel, as urologist, as a BPO surgeon, we mostly focus on the prostate. That is is an option sometimes, but it's probably not the solution to manage patients with the BPO and overactive bladder. So my question is, what is your strategy in patients with voiding and storage symptoms? What is your best option? Aquablation, HOLEP, minimal invasive treatments. So what is your opinion?
So my opinion, and I was very happy when I heard the talk about the future trial, and the talks before was that de-obstruction goes before treatment of overactive bladder because it resolves in many patients. And the thing we are afraid of, like doing surgery on a patient and the patient being completely incontinent and completely unhappy afterwards, is definitely we need to avoid that, but that's the very, very rare case.
Exactly.
And I would fully support what you said. We have to take carefully the history of the patient and make him write down everything when he, like the protocol, when what and when he drinks and when he needs to go to the bathroom, and then to decide if it's really necessary to do further workup. So I'm de-obstruction first, but after doing a good history of the patient, to not missing that one patient that might be unhappy afterwards. And regarding the technique of surgery, it's depending on what you can offer, like what you are able to buy for your hospital or for your practice and what you are able to perform. I talked about the steep learning curve of laser enucleation. To my opinion, that's definitely one of the best established and with good long-term outcome data technique, but you need to learn it from a surgeon who is able to do that. Aquablation is definitely an option if you are not able to learn that, but you want to treat large prostates and you don't want to cut the patient open anymore. That's definitely a solution. And in smaller prostates, we have different data definitely, and it depends on what the patient really wants. If he but if ejaculatory function is of importance for him, we should offer the patient other techniques than we did before. And if it's not a matter of fact, and there's a big difference in men, not depending on age, it's just difference in men, you can definitely do TURP, green light laser, any other minimal invasive technique.
But the object should be de-obstruct the patient. So if you have a patient with both condition and the surgery is an option, probably the goal is to do an obstruction. So last question for Manuela. The future trial question on the role of urodynamics in OAB in female, but we have the same discussion on male patients. So we always use the urodynamic in our clinics for a better evaluation of our patients. So what is the role of urodynamics in your practice for both male and female patients with overactive bladder?
Actually, I use urodynamics in very selected patients. I had recently a discussion with a colleague of mine, and we said maybe in the 80% of patients we are going to disobstruct in male patients, we use urodynamics, but probably only half of them need urodynamics. So this is what I use as my mind setting. I use urodynamics only when I'm not sure if I can miss that one patient who can be not happy with my medical therapy or with my surgical therapy in terms of disobstruction. So I want to be sure that what I'm giving to this patient is correct for him or her. So I use the urodynamic tests to be sure to treat in a correct way that specific patient. Yes.
So thank you both of you. I would like to thank you, Professor Ritter and Professor Tutolo, for their excellent presentation and to share some minutes with me and with the audience. Please enjoy the EAU Congress.
Thank you.